ultimately, for the lungs to function, we need to take air and bring it close to blood, right? So the deoxygenated blood needs to get very close to air. So because of this fact, we need to put air next to blood. Pulmonary capillaries are weird compared to other capillaries in the body, okay? I drilled into your heads that when a capillary is has too much oxygen or not enough or had too much oxygen, it will constrict, right? Well, in the lungs, it's opposite. Normally, oxygen is a vasoconstrictor. In the pulmonary circulation, oxygen is a powerful vasodilator. All right? Now, this makes perfect sense if you remember that we want to put blood where the air is. All right? So that means where there's air, in other words, where the oxygen concentration is high, we want to have vasodilation so the blood goes there. Right? So, pulmonary circulation, oxygen is a vasodilator. And it helps to do what's called ventilation perfusion matching. If we just move air in the lungs and don't put blood through it, that doesn't do us any good. If we just move blood through the lungs and don't put air in them, that doesn't do us any good. We need to have both things. And we need to have them in the same places. In other words, we need to have the blood where the air is and vice versa. So that's ventilation perfusion matching, or VQ. The letter we use for perfusion is Q. So VQ matching is ventilation perfusion matching. The most common way you're going to hear that phrase is as mismatch. A VQ mismatch, you know how we talked about pulmonary emboli the other day? Okay, if you block blood flow to one lung, well, you're still breathing, but you have a ventilation perfusion mismatch. You're ventilating lung and not perfusing it. You see? So you're going to end up with a falling oxygen concentration. All right. Another effect on the lungs, particularly in the human being, is gravity. All right? If you look at your dogs and cats, okay, their lungs hang from their spine most of the time, right? Because their spine is level to the planet's surface. Well, for us, we're weird. We stood up, okay, so now instead of our lungs hanging, they're sort of like leaning. They're sort of hanging down instead of straight down. They're sort of leaning down. So it means that the weight of the blood being pulled towards our feet creates a difference between the top and the bottom of the lung, right, in terms of blood flow. Okay, so blood flow on the y-axis, where we're at in the lungs on the x-axis. So we're going from top to bottom. So we can see that at the top of the lungs, up here in the apices, we have less blood flowing than we do down here in the bases of the lungs. All right. So, and whether we're at rest or in exercise, pattern is still the same, even if the magnitude is a little bit different. So the bottom of the lungs tend to get more blood flow. The top of the lungs get less blood flow. Okay, so because of that, we can divide the lungs into different zones. All right, so we have differential blood flow. Sorry, I keep flipping back and forth, but we have areas of low blood flow, middle blood flow, high blood flow. Same issue, gravity. On the air side of things, we have 3 air zones too. Okay, the air pressure in the lungs is going to interact with the blood pressure, and we're going to get 3 zones out of that. All right, so this is the alveoli. Okay, PALV is pressure in the alveoli. PPC should be capillary pressure. Why is that not on there? PPC is pressure in the capillaries. Okay. So up here in zone 1, all right, so we have arterial and venous blood. Artery going in, venous coming out. Look at the colors. We're in the lungs, remember? So arterial blood is blue, venous blood is red. All right, so in zone 1, the pressure in the alveoli is high enough that there is poor blood flow from the artery to the vein. Remember, capillary pressures are not very high to start with. Pulmonary pressures across the whole system are low, right? So it means pulmonary capillary pressure is relatively low. In zone 1, the air pressure in the alveoli is greater than the capillary pressure, so we actually have more V than we have Q, right? We have more ventilation than we have perfusion. In zone 2, it's approximately balanced, right? We have about the same amount of pulmonary pressure or alveolar pressure as we have venous pressure, so our V and Q are matched. And then in zone 3, we have plenty of perfusion, but now, because we're so low in the lungs, we have less alveolar pressure, right? So in zone 1, the air pressure is greater than the capillary hydrostatic pressure, so we get very poor perfusion. In zone 2, we get blood flow only during the peak of arterial pressure, right? Remember that arterial pressure is a curve, okay? So in zone 2, at systole, we're going all the way through unimpeded. At diastole, we have a small amount of flow. And then in zone 3, the air pressure is so much less than the hydrostatic pressure that we have constant flow. Okay, so I like to think of it as ventilation perfusion. Lot of ventilation, no perfusion. A lot of perfusion, no ventilation. Bit of both, right? Bit more matched. So zone 2 is actually where we're most efficient, all right, in terms of our gas exchange, because our ventilation and our perfusion are best matched. Now, these zones can change depending on what you're doing, all right? So like if you go into, like when you exercise, all right, you actually get more zone 1, and but the amount of you get more zone 1 and less of zone 3, for example, when you exercise. But we'll talk about effects of exercise in a different talk when we do regulation. Okay, so the lungs can take a lot of cardiac output, and they need to be able to. Remember, ultimately, our exercise tolerance is in part determined by oxygen delivery, right? So it means that if we're going to deliver maximum oxygen to maximum amount of muscle, well, we're going to need to move maximum amount of blood, right, through the lungs. So the lungs can accommodate an enormous increase in cardiac output. So like from 4 times to 7 times during exercise, it can increase. Now, when in that first slide, when I said the pulmonary circulation is low pressure, high flow, okay? That's kind of what this is showing you, that as cardiac output increases, the pulmonary arterial pressure doesn't increase very much, right? So like this is doubling. We to go from 4 to 16, that's 4 times, but we only see an increase in pressure of 2 or 3, right? This is proving that this is a high flow, low pressure system. That even though there's a lot of blood flowing through the lungs, the pressure never gets high, right? It never increases. Why? The number of open capillaries in the lungs can increase dramatically. In other words, right now as you're sitting here at rest, you are not using all your alveoli. Most of your pulmonary capillaries are not really being used, they're closed. But if you got up and exercised, they would all open up, right? So you can dramatically increase the number of open capillaries you have, up to 3 times as much. Each capillary can also get bigger and distend so that it increases its flow rate. So more open capillaries that are now bigger can accommodate more blood flow without a pressure change, right? So our pressure is still low, but we have lots and lots of flow. Now, slight changes in pulmonary pressure do occur, but these two effects, because of auto-regulation, dampen that effect out substantially. Short version of this whole slide, the lungs can accommodate a very large change in volume without a big change in pressure on the perfusion side. And that's good, because essentially this means that all we need to do to make the lungs work better is move more air through them, because they can accommodate plenty of blood flow. Okay. So if we look at the microcirculation in the lungs, we'll see some similarities to the Starling forces that we talked about the other day. First off, pulmonary capillary pressures are low compared to systemic capillary pressure. That reduces the hydrostatic pressure. Remember, hydrostatic pressure is an outbound force, right? Pushing fluid out. Well, in the lungs, the inbound pressure is quite a bit lower, so it means the hydrostatic pressure is very low. Okay? The interstitial fluid pressure is more negative in the pulmonary system. You can think of it as there's kind of like a constant suction from the lymphatic system in the lungs, keeping fluid out of the interstitial space, right? It's like a little vacuum cleaner, sucking stuff out all the time. Because if we don't, then that respiratory membrane gets thicker and becomes a barrier to diffusion. Okay, so we have a negative interstitial fluid pressure. Colloid osmotic pressure of the interstitial fluid is much less than we have in peripheral tissues. And alveolar walls are thin and weak, so we need to have a low pressure. And then finally, because of how our respiratory system works, in other words, that we have to create a negative pressure to pull air in, we have a continuous slight negative pressure in the interstitium that is slurping fluid out all the time, which I guess I kind of said already. Okay, so if we put all those together and we do our Starling forces, we can see that we have 7 hydrostatic pressure from the heart. Interstitial fluid colloid osmotic pressure is negative, right? So that is a outward pressure, so it's being pulled that way. Negative interstitial fluid pressure being pulled that way, so we add those up, that's 29. On the other side of it, the only force we have pulling back in is our plasma colloid osmotic pressure, right, from our plasma proteins. So our net is outward plus 1, and that's going to head to the lymphatics. Okay, so differences from systemic, there's much less lymphatic flow in the pulmonary system. And the pressures are much lower, and the interstitial space is kept negative so that fluid doesn't accumulate there.